Start the meeting.
Good evening all. Welcome to the 29th edition of the Ophthalmology PG Classroom by Kerala Society of Ophthalmic Surgeons. So we are usually discussing cases or spotters or what would come usually handy for postgraduates for writing their exams. So we have today with us the illustrious Dr. Santosh Honawar. So he is taking for us today. He's running through all the spotters in ocular oncology. An overview of ocular oncology is what he's planning. He is one of the best ophthalmology brains in the country as of today in India. So Santosh Honawar completed his college with 7 gold medals from the Bangalore Medical College, then went on to RP Center. And in RP Center, he was trained, and then he went on to become an oculoplastic surgeon. He had a Best Resident Award there also, and then did his fellowship at the Wills Eye Hospital, Philadelphia, US. And then he moved on to LV Prasad Eye Hospital, where he started the academic program for postgraduates there. And then he went on to move to Center for Sight. And currently he is a director of plasty and ocular oncology services at Center for Sight. He is the editor of the IJO and the most cited ophthalmologist of India. So he has immense experience in managing ocular oncology, and we will hear for his wise words of, in the next hour or so, we will have him talk to us. It will be an interactive session. If postgraduates want to ask some questions to him at the end of the session, he is free to do so. He's asking you to do that. So let us, without further wasting any time, acknowledge Dr. Srini Edaklon, who is my scientific committee chairman, who is making up a wonderful Drishti program in November. And over to you, Dr. Santosh.
Thank you so much, Gopal. I congratulate you and KSOS for this wonderful initiative. Is my screen seen? Am I audible?
Yes,
sir. Yes, sir.
Very well.
All right. So I'll go over some of the cases in ocular oncology. We can't finish everything, but we'll try to see how much we can finish in the next 1 hour or so. Everything from pole to pole, from the eyelid to the orbit, but I'll be concentrating on what is generally kind of important from the perspective of examination, either as a clinical spotter or a pathology spotter, or even for OSCE. When you look at these 3 pictures, it's very difficult to say who is bad, who is good, and who is ugly. That generally happens in a busy clinic. Everything looks gray, everything looks similar, but hidden would be something which is sinister. Only when I label this picture would you know who is good, who is bad, and who is ugly. This is a white tiger, but it has a unique identifier, that is a stripe. So every tumor similarly has a unique identifier, and we are going to go over some of the case examples. Now, what do you think is this? Anybody can answer. We'll start with Rolika.
So it could be,
let me tell you, this is a 65-year-old lady who presented with this lesion, which has been present for over 1.5 years, slowly growing in size. She has a history of scratching it off once in a while, resulting in temporary bleeding, which spontaneously stops.
It could be a basal cell carcinoma.
Describe it.
So it's a pigmented lesion involving the lower lid, in the middle 1/3 of the lower lid, with vessels over the surface. It's a multilobulated pigmented lesion involving the lower lid with prominent erythema and dilated vessels over the surface. There is no loss of lashes. The anterior margin is involved. However, the posterior margin is not involved.
Okay.
It could be a nevus
what about the surface itself? And it is hanging. The
Yeah.
base is just this, and rest of it is hanging. It is hanging over her skin. It is not affecting her skin here. It is just
Yes.
hanging over it. So what do you think is this?
It could either be a nevus or a basal cell carcinoma. So the good part would be
What about the surface itself?
irregular.
Do you call it papillary?
Yeah.
So, and the lashes are intact. So would you still think of a malignant lesion?
No, sir. It's a benign lesion because only the anterior margin is involved.
Okay, so what do you think it is now?
Like a benign papilloma of the.
Yeah, most likely it is a papilloma, squamous papilloma, right? And she's not immunocompromised, but she has higher age. So in extremes of age in patients more than 60 years, and those who are immunocompromised, those who have multifocal papilloma, you can think that it is related to that. It may even change into malignancy, which is squamous cell carcinoma. But otherwise, it is a very typical squamous papilloma, although the size is little large. What do you think is this? Also papilloma, right?
Yes, sir. But the.
Yeah, but this particular papilloma has change in color. So do you give any importance to change in color, change in vascularity? What are the features that will tell you that a papilloma is turning malignant? Change in color, right? As you see here, this has little bit more of vascularity. It has turned into pinkish white. Change in vascularity,
Or the ulceration.
bleeding, induration, and ulceration, right? And the base becomes larger. Otherwise, papilloma is supposed to have a small base and a larger lesion. But if the base becomes larger and indurated, and if lashes are missing in that particular area, possibly it is a papilloma turning into squamous cell carcinoma. Change in morphology and ulceration. So whenever there's a papilloma, you should look at these critical aspects. And over a period of time, if there has been a change in color, increased vascularity, ulceration, induration around the base, and a larger base would indicate that it is squamous cell carcinoma. And also marginal location, if it is located right at the lid margin and has a broader base. You see the base, apex still looks like a papilloma, but the base is very broad. This is inverted papilloma. This has a higher chance of becoming squamous cell carcinoma. So this was papilloma with the entire spectrum. So that is just the summary of what is said. Change in color, vascularity, and alteration in the base indicates malignancy. So this is something that is good can turn bad when in bad company, mainly immunocompromised status and age more than 60 years. Okay. Deepti, what do you think is this? Can you describe it? This is a young boy, 18-year-old, and has this for a while, about 3 months or so, rapidly increasing in size, recent history of multiple episodes of bleeding, spontaneous bleeding, which doesn't stop unless patched. Is Deepti online? Or any postgraduate?
Yes, sir.
Yeah.
So this is a large upper lid marginal lesion, almost half the length of the upper lid. It has a yellowish tinge to it with some dilated vessels over the surface with central ulceration.
Mm-hmm.
There's definite loss of lashes, obvious loss of lid margin architecture.
Margin you can't see, unfortunately, but yes, loss of lashes is very evident. Okay.
So the most common would be a sebaceous gland carcinoma, but the age is, I missed that.
18 years.
18 years, so it's a young patient. But still lid margin appearance looks like it's coming from the tarsus. Yellowish tinge sebaceous gland carcinoma would be the first type differential.
Okay, but I said it is very rapidly growing. So does sebaceous gland carcinoma grow rapidly?
No.
Does it spontaneously ulcerate, and does it present more on the skin surface than on the conjunctival side? This is as if it is overhanging.
Yes. So I would think of rarer malignancies. Probably, and it's got a little bit more of a reddish tinge to it. Probably a rarer malignancies like adenoid cystic carcinoma of the lid or a Merkel cell carcinoma.
Show that to a PG, but can you call this something very characteristic? This is a crater. This is not an ulcer. This is not a surface ulcer. but a crater. And what is that sign called? Umbilication. So what is characteristic? Which lesion has characteristic umbilication? Central umbilication, that is because of spontaneous necrosis.
Molluscum.
That's small, right? Any guesses? This is keratoacanthoma.
Okay.
Keratoacanthoma has a tendency to necrose itself because of its rapid growth, which outpaces its blood supply, and hence that central crater or umbilication. Very characteristic. It is actually a borderline lesion, mostly benign, but can have on histopathology features which overlap squamous and basal cell carcinoma. But it is actually a benign lesion. It is a variant of pseudoepitheliomatous hyperplasia. Almost 85% of all keratoacanthomas in the body happen on the face and 5% in the eyelid. And if it is multifocal, then there is a syndrome that is associated with it. Not often asked for PGs, but for ocular oncology fellows, you may want to remember it. Central crater, and because it spontaneously necroses, it may regress spontaneously. So if it's as large as this, obviously excision would be indicated, margin sparing excision and reconstruction. That's the closer picture of keratoacanthoma. It's actually a spotter. Even in the clinic, this is how it looks. Most of the keratoacanthomas size may be a little smaller or bigger, but most of them look exactly like this, with a lot of blood vessels, smooth lobulated appearance, and a central crater or umbilication. Okay, Subhav.
Yes.
This is an elderly man who has come to you for cataract surgery. He has a mature cataract and is not bothered about the eyelid lesion that he has. And he gives a history of trauma. He is a rickshaw puller by occupation, and he says that he has had trauma about 2-3 years ago, after which his lid got deformed. Lower lid has got deformed. Do you want to believe that history and just take care of his cataract and not do anything for his ectropion? He doesn't even have epiphora.
No, sir. This looks like a solitary lesion.
Two devices on.
Solitary lesion, which is pigmented, which is plaque-like, involving the medial canthus and the lower lid margin.
Okay. Yes.
With central loss of architecture of the lid, sir.
Okay.
More so goes in a favor of a basal cell carcinoma of the lower lid involving. Pardon, sir?
He has small pits.
Yes, sir.
Does it remind you of a fruit? Orange?
Yes. Purely orange
appearance, indicating that it is much wider than what is seen. But basal cell carcinomas generally are nodular or nodulo-ulcerative, isn't it? This is flat. Do you still want to stick to your diagnosis, or do you want to change your diagnosis? It has caused distortion of the eyelid because of desmoplastic activity. It is pulling the eyelid margin towards itself, and also there is loss of eyelid margin in the medial 1/3. So, yeah, which kind of basal cell carcinoma it is, if at all it is basal cell carcinoma? It is the morphiform basal cell carcinoma, which is a sclerosing type. Because of desmoplastic activity, it causes distortion of the eyelid margin. This is pigmented, and this pigmentation is not unusual in Asian Indians. This is secondary melanosis. But if it is not pigmented, such as Caucasians or fairer Asian Indians, if it is not pigmented, then you may not even notice the lesion because it's so inconspicuous. It is so flat, placoid, no ulcer at all, and you may attribute the lid deformity to some kind of cicatrizing process. Some of these patients actually undergo ectropion surgery with skin grafting, etc., because the lesion itself may be very, very inconspicuous. That is how it presents. It's a basal cell carcinoma, morphiform or sclerosing variant. Otherwise, basal cell carcinomas are nodular and nodulo-ulcerative, and more often than not, they are pigmented. In fact, clinical diagnosis in many of these patients is melanoma. But the most important sign that it is basal cell carcinoma is that it is periocular, loss of lashes is present, and it has even a subtle but an ulcer for sure. So nodular ulcerative lesion, which is periocular with or without pigmentation, and the margins are very crisp or diffuse. In smaller lesions, margin is very crisp, right? Whereas in the morphiform variant, margin is very diffuse. More common in the lower eyelid. And more often than not, presence on the skin side, surface, and if at all it involves the eyelid margin, the anterior part of the margin and the lashes, but generally does not go full thickness into the lid unless it is very advanced. So more of the lesion is on the skin side, is a point in favor of basal cell carcinoma. This is exactly how it looks. More of the lesion is on the skin side. That is the nodular component, that is the ulcerative component, has gone on to involve the eyelid margin, but not full thickness of the lid. Loss of cilia is an indicator of malignancy. When these gang up, there are many basal cell carcinomas, then it is called Golin-Gott syndrome. Golin-Gott syndrome is a cancer predisposition syndrome where there is calcification of Fox cerebri, odontogenic keratosis, and palmar pits. All right. So who is the PG who's present now? How many postgraduates are there? Identify yourself. Whoever wants to take it can take it. Otherwise, it will come back to Rolika.
Sir, this is a ulcerative lesion.
What is more prominent, nodular ulceration?
Sir, nodule is prominent.
Yeah, so then you straight away call it nodular ulcerative lesion.
Okay, sir. Nodular ulcerative lesion with eyelashes lost and involving more than half of the upper eyelid.
Okay. Predominantly present on the skin side or the conjunctival side?
Predominantly on the skin side, sir.
Okay, involving the eyelid margin as well.
Yes.
What about the margins?
Margin is lost, sir.
Margin of the lesion.
Margin of the lesion.
Margin of the lesion is erythematous.
Ill-defined.
Yeah, well defined, but erythematous. Okay. Then there is intrinsic vascularity.
Yes, sir.
So what do you think? What are the three most common malignant tumors of the eyelid?
So squamous cell carcinoma.
No, what are the three most common malignant tumors of the eyelid?
So basal cell carcinoma, squamous cell carcinoma, and sebaceous gland carcinoma.
In India?
In India.
Or Asians?
Squamous cell carcinoma.
Do you think squamous cell carcinoma is the most common in Asians?
Sorry, sir. Basal cell carcinoma.
Basal cell carcinoma is the most common eyelid malignancy in Caucasians, in the Westerners. In India, which is the most common eyelid malignancy? Sebaceous gland carcinoma, more than 50%. In fact, 50 to 60% of all eyelid malignancies in Asian Indians are sebaceous gland carcinomas, followed by squamous cell carcinoma and basal cell carcinoma in almost equal proportion. In some parts of the country, squamous cell carcinomas are more predominant, whereas in some parts of the country, where there is higher sunlight exposure, such as coastal areas, etc., then basal cell carcinoma is more prevalent. Otherwise, it is sebaceous followed by squamous and least of all basal in India, right? So this is squamous cell carcinoma, as you rightly said. Squamous cell carcinoma is also a nodular ulcerative lesion. Generally does not get secondary pigmented, whereas basal cell carcinoma, because of its chronicity, allows secondary pigmentation, whereas this is relatively rapidly growing, is not prone to secondary pigmentation, and it is more on the skin side than on the conjunctival side. So two lesions which are more on the skin side are basal cell carcinoma, which is really more on the skin side, followed by squamous cell carcinoma. And nodular ulcerative is common to both. Basal cell carcinoma is more flatter and does not have such an aggressive ulcer. It has only a subtle ulcer. And the margins are indurated in squamous cell carcinoma. And pigmentation is rare in squamous cell carcinoma. That's how you clinically differentiate one from the other. right? This is also squamous cell carcinoma. You can see how rapidly it has grown and has involved the orbit already. There's just a 1-year history. So summary of squamous cell carcinoma is that it is elevated nodular ulcerative lesion. More often than not, it has orbital invasion, especially if it is in the canthus, medial or lateral canthus. It has a higher tendency for orbital invasion. It also metastasis to regional lymph node. Whereas basal cell carcinoma hardly ever metastasizes. It is locally invasive. Okay. Any other postgraduate present?
Okay, sir. I'll be there, sir.
Okay, go ahead. Which one of this is a lesion and why?
So the second picture on the right hand side.
This
No,
one?
no. So the third,
We'll
the
number it for you if-
lower, yeah, third picture then.
Which one? If this is lesion, you're sure?
Third, yes.
Third is lesion.
Yeah.
You want to?
Not extending beyond the tarsus, so that is more likely to be a lesion.
How do you know it is not extending beyond the tarsus? Did I show you the posterior aspect?
No, that's true. So
Go ahead, tell me.
it's okay. So in the first picture, it looks
First
very
picture,
well defined.
tell me what is what. Now, first picture, what do you think is the clinical diagnosis? All are ladies in their 40 to 60s or 70s, 50 to 70s, let's say.
Okay, so out of all of these, if I were to say, then the first one looks
This one
more
is little
likely.
younger. This
Yeah.
is little younger.
Agreed, but that is quite nodular, and yes, it has that yellowish hue, which is indicative of it being a lesion.
You're tripping over your own words.
Yeah, true.
So,
It's
tell me,
confusing.
number one, which one? Rapid fire. Number one, what is the diagnosis?
All other three are SGCs, and one would be lesion. That would be 2.
Okay. What about this?
Epidermal inclusion cyst. So lid eversion is important.
Lid eversion is important. This is higher than the level of the tarsus. Lashes are still bushy, right?
Right.
Main gland orifices are not pouting, neither are they obliterated. And on eversion, you find thinning of the tarsus. This is?
Epidermal inclusion cyst.
Right. So in lesion, meibomian gland orifices would be pouting, larger, and would exude if you press because there is associated meibomitis. Posterior part, the tarsal base will not be thinned out like this, right? And lesion generally does not go higher than the level of the tarsus. This is definitely higher than the level of the tarsus. This has meibomian gland orifices totally not altered. These are not obscure, nor are they prominent. Lashes are not lost. So you should suspect epidermal inclusion cyst, right? And these two ladies definitely have sebaceous gland carcinoma, correct?
Right. Yeah.
So this one you said was lesion, but look at the lid margin.
Margin
is widened, higher than the level of the tarsus, definitely higher than the level of the tarsus. When you evert the lid, you find that both of them have sebaceous gland carcinoma. This one has a smaller one. This obviously is a very large sebaceous gland carcinoma. Now, in rare situations, what happens? This lesion may not be present at all, isn't it? So in that case, how would you diagnose sebaceous gland carcinoma from a lesion in this particular lady? What are the clues? That is very important clinically, exam point of view, in the clinical point of view mainly. So how do you diagnose a lesion from a sebaceous gland carcinoma? And you would go ahead with curettage or you would go ahead with
So, sebaceous gland carcinoma would either be like a solitary nodule or
No,
there
no, no,
will be
don't tell any of that. I just want from this picture, what are the clues that you have if this was missing? This lesion is very evident.
the lid thickening. The lid thickening is an indication, one.
Okay.
And there is chronic
Specific
blepharitis.
words, widening of the lid margin. You
Yeah.
can see this is the normal width of the lid margin. This is widened by 1.5 to 2 times. Widening of the lid margin is an indicator that you are looking at a sebaceous gland carcinoma most likely. Second
And
important feature, loss of
pouting.
meibomian gland orifices. So you see meibomian gland orifices are present till here and present here, but in this sector of the eyelid, there is loss of meibomian gland orifices. That is the second most important sign. The third is loss of sharpness of the posterior lid margin or rounding of the posterior lid margin is the third. Fourth would be presence of microvasculature in the eyelid margin. That would be the fourth. Fifth would be loss of flashes, and sixth would be an obvious lesion itself. So if the lesion is missing, for example, if it's an early lesion, the posterior aspect, the tarsal conjunctiva may not be affected at all. It may still be nodular. It may not have any manifestation in the tarsal conjunctiva. There is no ulcer, just a nodule. Then it is sitting right on the fence between a chalazion and a sebaceous gland carcinoma. Most of the ophthalmologists err in favor of diagnosing a chalazion and do an incision and curettage without sending it to histopathology. So that is the reason why chalazion, sebaceous gland carcinoma, early ones are missed, and only when they recur do they think of the possibility of sebaceous gland carcinoma. So whenever you have a what looks like a chalazion in an elderly individual, anybody who is beyond 45, 50, you should look at the additional features that, such as widening of the lid margin. I'm repeating again, loss of meibomian gland orifices, right? Rounding of the posterior lid margin, loss of eyelashes or sparse eyelashes in the involved area, the lesion itself, and microvasculature in the lid margin or marginal telangiectasia. So these are the features that you should actually look for to diagnose an early sebaceous gland carcinoma. Now, what about this? This patient had an incision and curettage, and this is a picture taken 1 month after incision and curettage that was available to us. So what do you think is the diagnosis?
But the
Looking at the skin texture, she is probably in her 60s, 70s, right?
This would be like a vegetoid spread of
No, forget
SGC.
about vegetoid spread for a moment, but you can see meibomian gland orifices right up to here.
Yeah, and then there.
In this area, it is absent, and there is a small nodule here already. There are no MG orifices here. Lashes are still normal, right? So this patient did not have pathology from her incision and curettage. This was her presentation after a month following incision and curettage. She did not come back for 3 months. 3 months later, she has an obvious increase in size of that small residual lesion. So this is actually a sebaceous gland carcinoma. Very early one, that is the reason why lashes are still not lost, but it is nevertheless a sebaceous gland carcinoma, right? So small one. So it's written in all the books, including Parson, that nodular variant of sebaceous gland carcinoma masquerades as a chalazion. Any recurrent or atypical in terms of clinical features or atypical in terms of age more than 50 years, warrants biopsy. That means even if you do incision and curettage, you're supposed to send the material for histopathology, and the fresh sample has to go not in formalin, right? So that they can do oil redo staining, especially in peripheral laboratories. They may not have other modalities. So oil redo staining is the best modality in basic setup, and they can confirm the diagnosis of sebaceous gland carcinoma. These are other morphological variants of sebaceous gland carcinoma. This is typically nodular. This is nodular overhanging lesion from the tarsal conjunctiva. This is nodular with a small ulcer, whereas this one is nodular with a little larger ulcer. All of them have a typical hue. All of them have loss of lashes or sparse lashes, right? So that is sebaceous gland carcinoma. Again, this is typical sebaceous gland carcinoma arising from the meibomian gland. This is predominantly marginal variant where there is ulceration of the margin. This may look like squamous cell carcinoma, but it is not. This is sebaceous gland carcinoma because the skin is not so much involved. It is the lid margin and the tarsal conjunctiva are mostly involved, which is unlike squamous cell carcinoma. Variants of sebaceous gland carcinoma. You can see how many morphological features does it have. Each one looks different. Okay. Deepti. Is she there still?
Yes, sir. Yes, sir.
Yeah.
There's the upper lid shows widening of the lid margin with an area of ulceration with a yellowish tinge to it.
Mhm.
There's no loss of lashes, although it seems to have been cut.
Yeah, lashes have been trimmed.
I can't see any meibomian gland orifices. So I would still think sebaceous gland carcinoma.
Do you think it's so common in the margin? If it was,
Uncommon
then
to
which
have.
variant it is? Which variant of sebaceous gland carcinoma would this be?
It's quite flat. I would like to invert the lid also and see the underlying surface.
Yeah, I don't have the
Yeah.
inverted picture, but there was nothing in
Yeah.
the lid tarsal
Could be
conjunctiva
attached.
except for this about 0.5 millimeter extending to the tarsal conjunctiva, that strip, but otherwise the posterior aspect was absolutely clear. There was nothing in the tarsus, there was nothing in the palpebral conjunctiva.
Could be a pagetoid variant.
Pagetoid is more common in the conjunctiva, isn't it? This is at the eyelid margin. So,
Oh, arising from the gland of Zeiss.
right. Yeah, so Zeiss gland tumors typically occur at the eyelid margin, and they also have an additional feature of early loss of lashes. But in this patient, lashes were preserved, so possibly it was arising somewhere there, and the lashes were still not lost. But this was a Zeiss gland tumor. Typically, it arises from the meibomian gland, and that is why it presents as a tarsal-based nodule. But not uncommon that it arises from the Zeiss gland and can have a diffuse involvement in some patients where both the meibomian and the Zeiss glands can get involved. Okay, Subha. Or any PG? Anyone? Quickly. You're muted.
Yes. So there is a diffuse diffuse involvement of the ocular surface.
This is how the patient presented, unilateral red eye.
Yes.
Okay, and this is the magnified appearance.
There's the loss of normal limbal architecture, sir,
Mhm.
with the involvement of the corneal surface,
Okay,
with presence of feeder vessels.
Mhm. And
there is no nodularity on the ocular surface.
okay,
With
it's all flat.
involvement of the,
Okay. So what is your diagnosis?
and possibly
So you just now said
diffuse.
that there is placoid diffuse involvement of the bulbar surface, limbus, and the corneal epithelium, right?
Yes, sir.
The entire ocular surface seems congested. So what's your diagnosis?
Sir, diffuse variant of ocular surface squamous neoplasia.
But this was an eyelid class, I thought. The initial pictures are all eyelid. No, we're still in the eyelid. Why have you missed looking at the eyelid? Is the lateral eyelid normal? Is this normal?
No, sir. There's a loss of the normal architecture, loss of
What
meibomian gland
architecture?
orifices.
Absolutely. Meibomian gland orifices stop there. There is no meibomian gland orifice in this area. And what about the lashes?
And there are loss of lashes. There are sparse lashes,
Sparse lashes.
in that area.
Right.
And
Do you want to
relative
invert the
thickening
lid
of the. Yes, sir. It shows the widening of the lid margin
Okay.
with the rounding of the posterior border, or loss of sharpness of the posterior border, loss of meibomian gland orifices in that area, with the loss of lashes and diffuse involvement of the tarsal conjunctiva.
Okay. So it has all the features of a nodular variant of sebaceous gland carcinoma, but the nodule itself is missing, correct?
Yes,
This you call it?
yes, sir. Vegetoid spread of the sebaceous gland carcinoma.
Well, we don't know whether it is pegetoid or bovenoid. We have to do a biopsy to prove that it is intraepithelial, or you can call it diffuse intraepithelial sebaceous gland carcinoma. Most common, of course, is pegetoid variant, right? How does pegetoid variant differ from bovenoid variant? What are the three types of intraepithelial spread? Pegetoid, bovenoid, and
Papillary.
papillary. Pegetoid is what is typical, very common. Bovenoid has keratin. Papillary, as the name suggests, has papillary surface, and that more commonly involves the bulbar conjunctiva. Okay. So what do you think is this? Left eye?
Yes. Sir, in the left eye, the lower lid shows again widening of the lid margin with loss of meibomian gland orifices, sparse lashes, loss of rounded posterior lid margin, and diffuse involvement of the bulbar surface of the conjunctiva and the cornea with vascularization.
So this is again intraepithelial sebaceous gland.
Intraepithelial sebaceous gland carcinoma.
Okay. Yeah. Are there any PGs present still, or have they dropped off? Then it comes back to Rolika.
Yes, sir.
Which one of this is not a nevus, or all of them are nevi?
So the fourth picture.
Is not a nevus.
No, it is also nevus. All are nevi.
All are nevi. So how do you differentiate a nevus from a melanoma in a clinical situation?
So melanoma would be like a more diffuse. It can have a site of bleeding or ulceration, and it is either arising from an underlying
that you wouldn't know clinically. When you look at a patient, you'll find again, because it's a malignant lesion, if it is around
like prominent
eyelashes, loss of lashes is a feature, whereas in nevus, lashes are typically not lost. In fact, they may be bushy, right? Vascularity, ulceration, and loss of sheen. Nevi have a shiny surface, whereas melanoma has a dull buffed surface. This is a melanoma. You can see small ulceration within it. It is not shiny, and the eyelashes in this area are lost. Malignant melanoma of the eyelid is one of the most aggressive malignancies because it metastasizes and also involves the regional lymph nodes. Okay, let's go to ocular surface. Now, Sohni or anybody, do you want to say what is this?
Like dermoid, like
what dermoid?
Stoma.
Your voice is breaking, Sony. You can.
Okay, so you can go ahead, Tolika.
So this is a conjunctival corystoma, and it's like
call it ocular surface or a limbal.
Yeah, it's like an ocular surface lesion. Most probably a corystoma. With so at the I will mention it like that. So it's at the temporal.
Can you simply call it a limbal dermoid?
Yeah, it's a limbal dermoid.
It is a limbal dermoid, right? So what are the indications for excision of a limbal dermoid?
So if it is causing astigmatism, if it is causing like prolonged corneal curvature difference, so that is one reason.
So astigmatism, then?
If the patient on looking down is able to see a U or a bulge, that is one reason. And of course, a cosmetic reason.
Okay. So in this particular dermoid, Why would you be careful? Otherwise, dermoid is a fun
Because
lesion.
there is a stromal hue which can be seen over here. That means that the
Not
depth
hue, it is hydration. If
hydration.
there is hydration of the stroma ahead of the lesion or vascularity that is ahead of the lesion, that means what?
That means that it's a deeper
Deeper
limbal
lesion,
dermoid.
and you may need tectonic repair, right? So you should be very careful in excising a lesion where there is hydration of the stroma ahead of it or vascularization ahead of it. Now, what do you think is this? This is a limbal dermoid with?
With preauricular skin tags, golden heart syndrome.
Auricular appendages, golden heart syndrome. Okay. What about this?
So this is also
Don't call it a giant limbal dermoid. There's some.
it's a limbal dermoid.
No, it is not.
It's a dermoid. It's a
corneal dermoid.
corneal dermoid.
It's a corneal dermoid. Corneal dermoid, you can't do much about it because generally it is associated with anterior segment dysgenesis. So only thing that you can do is either evisceration or enucleation for cosmetic benefit. You can't really give back vision because it's an embryonal lesion and the patients do have deep amblyopia even if there is no anterior segment dysgenesis. What about this?
This is this one's a fat prolapse.
Fat prolapse?
Yeah.
Then what is this?
Oh, this is a fat prolapse. That's like dermolipoma.
Just because I changed the sequence of the slide.
Yes.
Why do you call it dermolipoma? Why not fat prolapse?
So it depends on the reducibility and
This is a younger patient, isn't it? Obviously, a younger patient, a child. Color of the lesion is yellow, not pinkish. And
it's more diffuse. There's no overhang. Like, in a fat prolapse, there will be like an overhang.
This has a slight
concave
flexion,
angle.
whereas fat prolapse will have a crevice, right? Yeah, crevice like this, and it is easily reducible. And fat prolapse is bilateral in stocky individuals with a short neck. Okay, fat prolapse is seen in older individuals. Only condition where fat prolapse can be seen in a younger child is systemic association is fat prolapse in a younger child. 3 syndromes. Downs, Hurlers, and Hunters. These are children with fat prolapse which can be seen. What about this, Deepti? Present by birth, high astigmatism, no other symptoms. Present superonasally. Limbal dermoids are generally inferior, infrotemporal most common, followed by infronasal. When something happens in a different location and is much flatter and much whiter, has irregular surface, then you think differently. What is this?
Okay, no keratocanthoma.
By birth.
By birth, okay.
Are you sleepy?
No.
It's a complex choristoma, probably.
Well, that only pathology can tell you, but this has a hard surface, and when you do B scan, there is shadowing. Or when you do CT scan, for example, in this patient, you might find calcification, mostly calcification. So this is osseous choristoma. So choristomas can be glandular and osseous, and this is actually a glandular choristoma. This was nothing but an ectopic lacrimal gland in the cornea. This is histopath proven. So choristomas can be osseous and glandular and complex. This is complex choristoma. So in addition to complex choristoma, skin tags, you find greasy looking nevi on face, chest, and abdomen. Then that becomes a cancer predisposition syndrome called nevus serrations of Yada. Right, Subhav. 50-year-old lady who has had renal transplantation, and obviously she's on post-organ transplantation immunosuppression. What are these two things that you see here?
Involvement of the lower palpebral tarsal lower tarsal conjunctiva,
Okay.
with a pinkish placoid, slightly elevated lesion involving the medial canthus along the posterior border of the lid margin, and involving the meibomian gland orifices at its margin, anterior margin.
It's just overhanging. It's just overhanging. We are in the conjunctiva now, so don't worry too much about the eyelids. It's overhanging. So it's basically like this, right?
Yes, sir.
And there is a central blood vessel from which there are blood vessels which are radiating. So what is this typically? And the base is small. And if you lift it, you'll find a small pedicle which is connecting it to the palpebral conjunctiva. This is typically conjunctival papilloma, right? Conjunctival papilloma is more common, just like skin cap papillomas, in immunocompromised individuals. This is also a papilloma, but the aggressive variant. This was seen in a young child with HIV by birth, child of a mother with HIV. So it can also be seen in children in a very aggressive form in HIV positive individuals. Okay, so that was papilloma. Now coming back to Rolika, what do you think is this?
So it's a conjunctival surface lesion involving the temporal limbal area. It is well defined with a prominent feeder vessel with the keratin on top. Rose Bengal staining is positive. And
how do you know that we have done Rose Bengal staining?
So it is seen.
So you've taken pictures without cleaning it off.
Okay. Okay, so there is keratin on top, and it looks, and there is limbal involvement. So there is a corneal overlap, and this is suggestive of ocular surface corneous neoplasia.
So if this is the limbus, it is epicentered in the limbus with a larger corneal component and a smaller conjunctival component, with blood vessels that are supplying this hungry lesion from all locations, episcleral blood vessels, some deeper intrascleral channels, some conjunctival blood vessels, everything. So this is ocular surface squamous neoplasia. So three features that you said were limbal location,
keratin on top, and the prominent
and intrinsic vascularity, and Rose Bengal stain positive. It is the most common conjunctival malignancy in tropical countries, huge clinical spectrum. Some of these are pigmented, and you may get confused that it is conjunctival melanoma, but it is not. And the most important triad of features are keratin, abnormal vasculature, and Rose Bengal staining. So if only keratin is present, it is still reasonably sensitive and specific. Keratin and abnormal vascularity is much higher in terms of sensitivity and specificity. And addition to that, Rose Bengal staining makes it almost as good as the gold standard, that is histopathology, right? If you still have any doubt, then you look at the OCT, anterior segment OCT. What are the anterior segment OCT features in OSSN?
So there will be so it's written there. So there is a thickened hyperreflective epithelium, and there will be an abrupt transition between the corneal surface and the lesion, which is seen over here. That is the difference between the normal epithelium and the lesion per se.
So just say that hypoplastic, hyperreflective corneal epithelium with abrupt transition. That these are the features of OCT features of ocular surface squamous neoplasia, right? And syndromes that are associated with it are xeroderma pigmentosum, immunosuppression of any cause, and palmoplastic keratoderma. So you should look for all these, especially in patients who have multifocal or bilateral OSSN. Okay. Right. Deepti. Is she there or has she gone for eye focus?
So I'll be back in 15 minutes. Deepti is here.
Yeah. Deepti, go ahead. Which one of this is not any which you think?
So the first one is in the palpebral aperture, has small feeder vessels, not very pigmented.
Sir, the fourth picture is a
Like
What?
fourth one is a nevus.
Fourth one is the nevus or not a nevus?
Is a nevus.
And others?
fourth may not be a nevus.
And the others?
The second is slightly more nodular, one feeder vessel, but that can be seen even in a nevus, but it is abutting the limbus and encroaching onto the cornea.
Okay.
That's the only atypical feature. The third one also is pigmented. Looks like there are some cystic spaces within it with
all
one
are
feeder vessel.
pigmented lesions with variable pigmentation. 3 of them are in the interpalpebral bulbar conjunctiva.
The fourth is an atypical location.
Fourth is an atypical location. Okay. So which one is not a nevus now? Or all of them are nevi?
I would say fourth is not
a nevus. Okay. So let's go through this checklist. 3 of them have interpalpebral location. 1 of them is superior. All of them have variable pigmentation. Nevi vary in pigmentation from tan brown to dark chocolate brown. Variable pigmentation is a hallmark of a nevus. They don't have corneal epithelial invasion. You may say that this has corneal epithelial invasion. It is just the overhanging of the nevus, which is a nodular nevus on the corneal epithelium. If it were to be true corneal epithelial invasion, it would have jagged margins with pigmentation carried over, with vascularity carried over. No episcleral fixation. When you move a nevus over the bulbar surface, it moves. When you move it with a cotton tip replicator, it moves over the episclera. All of them moved. And there is no intrinsic vascularity. Feeder vessels are present in almost every nevus. In fact, all of them, all the 4 have feeder vessels. This has a feeder vessel, this has a feeder vessel, this has a much prominent feeder vessel, and this one has 2. So feeder vessels are not a contraindication to diagnose a nevus, but intrinsic vascularity is. That would look like actual blood vessels within the lesion. That would be a feature that does not gel with the nevus, but otherwise all these 4 are nevi. This is an atypical location, but it is a nevus by other aspects of the checklist. But the most important one is still the microcysts. Nevi are spongy. And when you look at this nevi on slit lamp, you'll be able to identify some cysts. And if you have doubt at all, then you can do anterior segment imaging to see if there are microcysts and cysts. But all of them are nevi. Okay. So cysts are seen in about, so this is Western data. We have a large Western series of 5,000 odd cases. Pigmented lesions, nevi are pigmented in 85% in the West, non-pigmented in 15. In India, I would say about 95% of nevi are pigmented and maybe less than 5% are partially pigmented or light pigmented or non-pigmented, depending on the age of the patient, the race of the patient. And even in India, being a multiracial society, there are possibilities of very fair-skinned individuals where nevi can be amelanotic. Cysts are present in about 2/3. So cysts are there in 2/3, but presence of cysts is not diagnostic of a nevus. Cysts can even be present in lymphangiectasia, lymphangioma, etc. But then a pigmented lesion with cysts, you should definitely consider the strong possibility of a nevus. Okay, when the cyst changes, when the cyst disappears and nevus becomes more solid, that means that it is transforming into a melanoma. That is obvious clinically as in this situation, and also the fact that there is intrinsic vascularity in the transfer part of the lesion. It's a melanoma. If you have any doubt at all, you can do anterior segment imaging. Okay, Subhav?
There's a nodular lesion in the interpalpebral area at the limbus with the presence of feeder vessels. The lesion is pigmented, has a variable pigmentation. There's a
variable pigmentation, but this is fleshy. This is not
fleshy.
like pigmentation which I showed earlier. It is not like this kind of pigmentation. No, all shades of brown is variable pigmentation. Whereas if it's a dark colored lesion with the fleshy component, that indicates there is extreme vascularity and this is an aggressive lesion. And it is not like overhanging the epithelium. It is like going into the epithelium aggressively. And there is vasculature in all the layers, deeper scleral vessels, episcleral vessels, conjunctival vessels, feeding this hungry tumor. So what is it likely to be?
A conjunctival melanoma.
Conjunctival melanoma is the most likely diagnosis. Okay. Yeah. Now, pigmented lesions of the conjunctiva, the others are, all of us will have some pigmentation, but if it's bilateral, symmetrical or nearly symmetrical and has this cobblestone kind of architecture, with or without fine pigmentation in the peripheral cornea, some of which can extend right up to the inferior fornix or superior fornix, but tarsal involvement is not present, then it is racial melanosis, right? Racial melanosis or complexion associated melanosis is something which is very common. Management is simply observation unless the patient is cosmetically worried. But when you have gross asymmetry like this, of course, left eye is slightly pigmented as is appropriate for age and the race of the patient, but the right eye shows gross amount of pigmentation all over. If there is such gross asymmetry, then you should rule out primary acquired melanosis. So asymmetry and also paper-like dusting of pigmentation, not the typical cobblestone architecture, and localization of that pigment to a particular quadrant or a sector of the vulva conjunctiva, involvement of the fornicial conjunctiva and the tarsal conjunctiva, which is not present in case of racial melanosis, is indicative of primary acquired melanosis. You should always identify a primary acquired melanosis from racial melanosis and NEVA, etc., because primary acquired melanosis has a high predisposition to turn into melanoma. The number differs from different series, but then every clock hour extent of PAM has a 1.7 odds ratio of turning into a melanoma. So larger the PAM, more is the chance of transformation. Okay. Now, Deepti, back to Deepti again. This patient comes with enophthalmos, and this is what you see on the conjunctival surface. She has enophthalmos clinically.
Yeah, if there is enophthalmos, I'll be thinking more in lines of orbital varix, and this could be a conjunctival component of the venous.
Right. So this is conjunctival component of orbital varix, and this is how it manifests when the patient does Valsalva maneuver or bends down. So whenever you have a conjunctival vascular, larger vascular channels like this, it's a good idea to do Valsalva maneuver and also bend down test, where if the proptosis increases by more than 3 millimeter in 3 minutes, it's considered positive, or on Valsalva if there is increase in more than 3 millimeters. So that is orbital varices. Now what about this acquired lesion in a 60-year-old lady? It was never present earlier. Now she comes with an acquired lesion, which is paralimbal with large vascular channels.
An acquired capillary hemangioma.
An acquired capillary hemangioma is a possibility here. Subha, what about this clear cyst in a 20-year-old lady? And some of these cysts have. What is this? She has just recovered from a episode of subconjunctival, spontaneous subconjunctival hemorrhage. This picture has been taken after the subconjunctival hemorrhage has resolved. So what do you think it is? And there is altered blood in the cyst, which is gravity dependent. It has settled down at the bottom of the cyst. This is which lesion which is cystic in the conjunctiva bleeds spontaneously? Lymphangioma?
Yes.
Yeah, this is a small lymphangioma, whereas this is much extensive lymphangioma and this is much more aggressive looking lymphangioma, but all are different grades of lymphangioma. Okay, who else is present?
Sir, I'm there.
Yeah, Soni or Saili hasn't opened her mouth, and there is somebody called Radhika and a big man called Gopal Pillai. So let's ask Saili Bavankule. Please answer.
Good evening, sir.
Good evening.
So, this is a
Do you want the history?
yes, sir.
45-year-old male with a history of having noted subconjunctival hemorrhage first. And then when he lifted his lid, he found this. This has been rapidly growing over the last 2 weeks.
Uh, so, I
Further inquiry reveals that he is HIV positive. Vascular lesion in an HIV positive individual that is rapidly growing.
he meant
Which is a tumor that occurs in immunocompromised individuals.
hemangioma.
It's sarcoma, Saili?
Yes, sir. Can be sarcoma.
Which type of sarcoma? Is there a name to it? Kaposi sarcoma?
Yes, sir. Kaposi sarcoma.
Yeah. So if you find a vascular lesion that grows very rapidly, conjunctival or eyelid, in an immunocompromised individual, you should suspect Kaposi sarcoma, and obviously it needs to be treated. Let's go to a different case. Let's ask one more PG who's present, who hasn't opened a mouth. Radhika. Yeah.
Good evening, sir.
Good evening. So this is a retired professor who takes care of eyes very well. She has never noted anything abnormal in her eye, but she suddenly noted that there was blood in the medial canthal area around the caruncle. Okay, so this lesion has also spontaneously bled. So I'm showing you a series of cases that have spontaneously bled. We started with this lymphangioma, which had recovered. Now Kaposi sarcoma, this is the third lesion that has spontaneously bled in an elderly lady. Okay, so do you think it is just the resolving subconjunctival hemorrhage in the medial canthal area, or do you think there is more to it?
So I think there's more to it, sir.
What is it? Do you see something orangish lying in the background?
Yes, sir.
A plica is totally replaced by something which is orangish.
Orangish.
Caruncle also seems hypertrophic. So which is this
Yes, sir.
orangish lesion which can bleed spontaneously? Subhav, Deepti, you want to help her?
Xanthogranuloma.
Xanthogranuloma of the conjunctiva is rare, no?
Amyloidosis, conjunctival.
Amyloidosis is perfect. That is the correct answer. Amyloidosis actually can bleed spontaneously, and it can even present like this. This was a bilateral contact lens wearer who had unilateral contact lens intolerance, and when we everted the eyelid, we found these translucent lesions which started bleeding spontaneously. There are some streaks of blood already. Picture was taken after cleaning, but then spontaneous bleeding of a translucent orangish pinkish conjunctival lesion indicates that it is amyloid. Okay, who else is present? Radhika, Soni. Okay, Soni, you take it. Do you think it is episcleritis?
No, sir.
Why?
Sir, this is more of fibrotic proliferation than vascularity, sir.
What proliferation?
Uh,
You see histopathology there. Is it fibrotic proliferation?
yes.
Huh? What is the color?
Sir, it is more of whitish.
White. This is white. This is
Yellowish.
white. This is?
Yes, sir.
What is it? What color?
Yellowish, pinkish.
Yeah. So, do you eat fish?
Yes, sir.
Salmon patch.
Salmon, salmon patch or salmon pink color, indicative of
Lymphoma.
lymphoma. Okay, you can just call it a lymphoproliferative lesion because you will not know clinically whether it is lymphoma, atypical lymphoid hyperplasia, or benign reactive lymphoid hyperplasia. Salmon pink color indicates that there is a lymphoproliferative lesion, and only pathology, histopathology, would confirm the diagnosis. So irrespective of its size, so this is a very large salmon pink lesion, and you can see various sizes of salmon pink lesion. The pinkness remains the same, but the diagnosis can be different, ranging from benign reactive lymphoid hyperplasia to lymphoma. So any patient who has a salmon-colored lesion which is diffuse needs a biopsy. Okay, so I have finished eyelid and conjunctiva. Obviously, intraocular tumors is a long thing, so we won't be able to take it now. If Gopal permits, maybe some other time we can do that. Intraocular and orbit. Gopal, is that okay with you?
Sure, sir. Sure.
So can we stop here? Or if there are any questions, I'll be happy to answer.
If there are any questions from the postgraduates, you can ask the master.
Yeah, sure. So do you have anything on the chat? You're muted.
Nothing on the chat, actually. Everybody was busy. Any
of the panelists have any question?
The difference between lymphangioma and lymphoma of conjunctiva.
Lymphangioma is it's a early onset lesion. Lymphangioma is typically congenital, but it may be so subtle that it may not be noticed at birth. But it is an early onset lesion. Lymphangioma is a benign lesion. It's veno-lymphatic malformation, more common in the orbit, but rarer forms happen only in the conjunctiva, but generally it has an orbital component as well. Localized conjunctival lesion is rare. Whereas lymphoma is a malignant tumor. Lymphoma occurs in elderly individual, and the only lymphoma that occurs in a child is Burkitt's lymphoma, but that is in the orbit. Conjunctival malt lymphomas occur in elderly individuals. It's a malignant.
So one question. So if you have an orbital lymphoma with a conjunctival component, you would prefer to take biopsy from which section?
So obviously conjunctival component.
Okay. So
Most
even
component.
And so you believe that the peritomy should be done, so and it should be raised instead of taking a direct
Right, it is
biopsy.
a subconjunctival lesion. It's a conjunctival stromal lesion. So you can preserve some conjunctiva and reconstruct the ocular surface if you were to go under the conjunctiva.
Right.
Thank you, sir.
That's it. Gopal?
Oh, thank you, Dr. Santosh, for that wonderful 1 hour. I was also hearing that. I was just driving the car, but I was hearing it. It was really wonderful. It's always a pleasure to hear through your talks and how you come to a proper diagnosis by excluding the others. It's really wonderful, and your fellows have, I think they must be immensely benefited by each minute of interaction with you.
Thank you so much.
Thank you very much. And in my name, as well as in the name of Kerala Society of Ophthalmic Surgeons, I thank you deeply for coming in. And I think we should have, as you said, an orbital, one more session on orbit, and probably on some of the, choroidal retinal tumors as well. So
Sure.
that we have
Whenever you have that, we'll do.
All right.
Thank you so much.
Thank you very much. Thank you very much for
Good
this.
night.
Thank you. Good night.